Good afternoon, ladies and gentlemen. My dear friend, Dr. John Wall, and dear colleagues, it's my great honor to moderate this session. And for the session 3, the title is "In General Population HCV Elimination Initiative in Asia Pacific regions." So I'm Minong Yu from Kaohsiung Medical University, and also the National Sun Yat-sen University, Kaohsiung at Taiwan. Next slide, please. Next slide, please. Okay, here. Okay. Next slide, please. Okay, this is the figure of the disease burden of chronic HCV by living in patients. It's estimated around 58 million people are living with the virus in 2019. And of this population, around 10 million people are living in the Western Pacific region, and another 10 million people living in Southeast Asia. Next slide, please. So the WHO set the goal of HCV elimination by 2030. But if you see this figure, you can see the expected HCV incidence and mortality trends from new action implemented under the strategy is denoted by the solid lines, versus no new action denoted by the dotted lines from 2020 to 2030. If there are no any action implemented, the new infection people will maintain at 1.4 million per year, and the HCV rate days will maintain at around 250,000 days per year. So only implemented the new action, we can have the hope to reach the WHO goal and decrease the new HCV infection to 350,000 and decrease the HCV rate days to less than 140,000. Next slide, please. So in this session, we are happy to have three speech from Taiwan, Japan, and Korea, and also a special lecture from Professor Omada. So right now, I would like to introduce the first speaker, Professor Wu Chonghui from Kaohsiung Chang'an Memorial Hospital, who will share the screening and testing strategy for the people living with diabetes. So let's welcome Professor Hu.
Thank you. Thank you, Professor Yu, for your kind introduction. Today, I'm going to talk about the elimination activity in persons with diabetes. It is a learning from Zhanghua integrated program to start hepatitis C infection. We call that as CHIP-C. So Taiwan's government has conducted the policy direction, core strategy, and universal DA reimbursement since 2019. And we announced national elimination by the end of 2025. Zhanghua County was located in the central part of Taiwan. The Public Health Bureau is in charge of 27 local health centers in different townships. And the Bureau have conducted CHIP-C program to follow up the national policy. By the previous experience of screening more than 123 participants in the county, the prevalence of HCV infection was 3.25% in general population. In addition to the high-risk populations, such as methadone treatment, HIV patients, prisoners, dialysis patients, there are also moderate risk populations, such as pre-ESRD, CKD patients, diabetes, and cardiovascular disease. Screening of these populations for HCV is very cost-effective because they belong to large volume populations. So the chip C means a big chip containing many small chips, including different programs, institutions. So we have to do collaborative care with endocrinologists, nephrologists, GP, psychiatry, and infectious disease doctors. Before chip C, we have conducted an age period cohort model according to the prevalence of different townships in the county. We would like to estimate the exact number we have to treat in the program according to the positive HCV RNA with 70% positive or 80% positive. So in the county, as you can see, the prevalence of HCV infection was much higher in the southwest area, rural area, when compared the northeastern area, urban area. However, most of the medical facilities were located in these areas. So in the rural area, there is a shortage of medical facilities like gastroenterology clinic or hospitals. But there is local health center in each townships in these areas. So they can become the basis to care HCV in community. So in the county, Zhanghua County have well-established diabetes shared care program since 2004. There is Diabetes Health Promotion Institute in each township with complete list of diabetes patients. So for diabetes population HCV care, we combine HCV and diabetic care together to facilitate the screening, diagnosis, referral, treatment during patient regular visit in their diabetic clinic. So by utilizing the diabetes care system for HCV elimination, here, there have been more than 10,000 diabetic patients in 27 local clinics in the community. So by 6-step implementation, such as simplified process, HCV plus diabetes testing, and the streamlined referral, we can easily reach the micro-elimination of diabetic population in this program. You can see that there is significant improvement after the implementation of the program. It means there will be no extra patient visit, no blood draw twice, and no duplicate procedure and paperwork. We further extend the model to all diabetic patients in all institutes and hospitals in the county. There is a big volume of target population, more than 66,000 patients. So as you can see, there are still a very high coverage of HCV testing, linked to care RNA testing, and the coverage of treatment. After 5 years of work of chip C, as you can see, there are nearly 5,000 participants have been screened for HCV. And mostly the older people aged more than 50 years old. The HCV RNA testing is 76% with positive rate of 76%. Totally, there have been more than 14,000 patients have been treated. The coverage of treatment reached 90%. So in the left figure, you can see that by the CHIP-C, a county-wide HCV elimination model has been achieved based on the original estimate with 70% positive for viremia. However, the exact viremia is right now 76%. And there are still 4 townships left uneliminated. We had to do the further work on these townships. After the successful model of CHIP-C, we further replicate the model, especially diabetes elimination model, into my hospital in 2021, Kaohsiung Chang'an Memorial Hospital, and extended to other branch of Chang'an Memorial Hospital in 2022-2023, which was led by Deputy Professor Jianlong Ran. So this is also a big volume target. You can see that more than 49,000 diabetes patients with a very high HCV testing, 85% are linked to care, and treatment coverage more than 92%. After the elimination model in hospital, you can see that there is significant improvement of care cascade outcome before and after initiation of HCV elimination program, such as antibody testing, RNA linked care, and treatment coverage. In the right table, you can also see there is significant improvement or all liver profiles after treatment, such as APRI and FIFO index. The SVR rate of diabetic population in hospital by DAA was 97.8%, which was similar to other special population. So ladies and gentlemen, in conclusion, diabetes is one of the important and big population, about 2 times of prevalence of general population. A novel community and hospital-based models were successfully implanted by combining the diabetes and the HCV care work. There is also a significant achievement of county-wide elimination from CHIP-C by collaboration between different disciplines. It is very important for HCV elimination in any other population. I thank you for your attention.
Thank you very much, Professor Hu. I think it's a great model in the micro-elimination based on the precision strategy. So because we will have a panel discussion of the, at the end of this session. So here I would like to invite the second speakers, Professor Tadashi Ikegami from Tokyo Medical University, Ibaraki Medical Center, Japan, to share the HCV screening strategy for the general population in Japan. So, ladies and gentlemen, let's welcome Professor Ikegami.
Good afternoon, everyone. Thank you, Dr. Yu, for your kind introduction. And also, I greatly appreciate to Dr. Ward and CGHE members and Professor Shina, president of this APASO meeting, for organizing this forum and giving me this opportunity. This disclosure. First, I will briefly mention the history of Hep C in Japan. It is assumed that most of the elderly Hep C patients in Japan were infected by transfusion of contaminated blood or blood products under the blood selling system. The blood selling system was abolished in 1990, and the using of disposable syringes and needles at medical facilities became standard around 1988. This suggests that infection may have spread endemic in the region, mainly through the injection. performed at the medical facilities and before that time. After the cloning of HCV in 1989, the blood donor test was studied, and the post-transfusion infection decreased dramatically and then disappeared. The infection rate among first-time blood donor has reduced on the current level of about 0.13%, which indicate the decline of HCV prevalence among in general population in Japan. The current Japanese policy against viral hepatitis was established based on the law called the Basic Act on Hepatitis Measure, issued in 2009. Under this law, the nationwide system for prevention, screening, and treatment has been formed. This slide shows that the patient with viral hepatitis can receive a generous lifelong support structured based on this law. Today's talk focuses on the screening strategy of Hep C in Japan. We have a lot of opportunity to do that. Under the Health Promotion Act, the milestone checkups, municipalities offer the milestone checkups for individuals who have never undergone screening at the age of the 40s and every 5 years after that. Additional screening is also available for those out of milestone ages with abnormal liver function and history of extensive surgical procedure or heavy bleeding. Each public health center offers a hepatitis virus test free of charge and anonymously as a part of a countermeasure project for specific infectious diseases. The pregnant women are screened in prenatal checkups. In addition, the testing is routinely performed in the medical institutions as an infection check before surgery or invasive procedure. Milestone checkups were started as a part of the geriatric healthcare program in 2002. Sorry about the layout of the graph. During 5 years of screening, based on this program, between 2002 and 2006, about 9 million people were tested, and 100,000 HCV positive cases were discovered. From 2008, the Health Promotion Service took over the program. Additionally, in the same year, a specific infectious disease testing service were added to widen the availability of the test. From 2010 to 2017, about 10 million people were tested, and the HCV prevalence, positive rate in general, the tested person is 0.33% in 2017. So what percentage of the general population has already been tested in Japan for Hep C? Professor Tanaka's group has conducted several nationwide surveys. In these surveys, self-administered anonymous questionnaires were sent to the randomly selected residents. The respondent with a history of blood donation, childbirth, or surgery, but no self-awareness of the testing defined as unrecognized testing. The latest survey was conducted in 2020, when questionnaire was sent to 20,000 persons, and 44% responded. The testing rate, including unrecognized testing, increased by more than 10% from the initial survey conducted in 2011. However, the research group realized that the not tested group shown here might not include the person of a previous public test recipient unaware of the test and without a history of blood donation, childbirth, or surgery. So they conducted a different study for persons who have a hepatitis virus testing during health checkup. This study revealed that many people forgot the testing history in the public health checkups. Then, adjusting the nationwide survey result with the forget the public test proportion ratio, this one, the HCV testing rate among the general population can be estimated as 76% currently. This presentation will be given by Professor Sugiyama, one of the members of the group of Professor Tanaka's in this APASL meeting. The surveyable patient who recently treated with DAA show that 70% recognized they were first informed about the infection in medical institutions, while the lower percentage said it was noted by public testing. Japanese healthcare providers still almost routinely perform the hepatitis virus testing as an infection check before the surgery or invasive procedures. Our facilities data show that department with many history had many tests, and the proportion of HCV antibody positive person was also high. The most patient in specialist clinics have already been treated, so the linking the patient found by these non-specialists to care is essential to reaching their elimination goal of treatment. The preoperative tests are excellent opportunity to reaching to discover the newly diagnosed patient, as well as the person's reminder of the persons of a previous test. In 2018, the Ministry of Health, Labor and Welfare requested that each medical institution to notify the patient of the hepatitis virus test result when it was performed as a part of preoperative checkups. To address this request, we have integrated the test result notification method into our hospital's admission management system. The preoperative tests were ordered in our clinic before patient hospitalization. So the blood sampling and testing are done in laboratory, and the lab tech sorts the test result, and the positive results are sent to the hepatitis medical coordinator and as well as attending physician. Coordinator asks the attending physician to disclose the test result to the patient during hospitalization. Negative results are sent to a admission and discharge preparation center, a station guided hospitalization, and gather the information for area discharge. After admission to the patient will notify the test result in orally and in document. Negative result was notified by inpatient wards such as nurses, and positive result was informed by attending physician and medical coordinator. If patient were not treated or not followed, the consultation to a specialist is recommended. When patient agreed the consultation, the doctors refer the patient to a specialist. In this system, we can efficiently connect the patient with active infection to care. Lastly, I'd like to introduce the current treatment status in Ibaraki Prefecture where I work. In this graph, the purple line shows that the estimated number of HCV positive persons by birth year. Well, it is based on the public testing-led data. The blue line also indicates the number of patients who use the subsidy program for treatment. Since most patients utilize the subsidy program for the treatment, it is very helpful to grasp the total number of the patients treated. The treatment for Forum-2 patients born in 1940 to 1960s seems to be satisfactory. So we are getting closer to goal, we believe. Summary, in Japan, the basic act on hepatitis measures was issued in 2009, following a nationwide public health checkup started in 2002. Test rate is likely achieved to the elimination goal, and easier access to medical facilities in Japan is advantageous. The key to overcoming this situation is the participation of co-medical staff and the collaboration with non-specialist doctors and immediate action after getting the test result. And also, I want to notice that the prevalence of active HCV infection in the general population in Japan is declined. So probably installment of a trackable recording system for testing and treatment history should be considered like Taiwan. Thank you very much for your attention.
Thank you very much, Professor Ikegan. So we will have a panel discussion later. So let's move to the third speech by Professor Jonggi Choi from the Asan Medical University of Ulsan College of Medicine. He will share the HCV nation screening and elimination strategy in Korea. So ladies and gentlemen, please join me to welcome Professor Choi.
Professor Yu, thank you for the kind introduction, and I'd like to express my gratitude for the organizing committee to give me this great opportunity to present HCV national screening and elimination strategies in Korea. I'd like to start with this graph indicating where we are now in the journey of the HCV eliminations. When we look at the Korean data, it looks pretty fine. I think we've already achieved the decreasing mortality, and then treatment rate has been already achieved. However, the problem lies on the underdiagnosis, and probably we are not detecting new cases as we expected. So this is basically the fact sheet which is published almost 3 years ago in Korea, supported by the KASE, Korean Association for the Study of the Liver. This fact sheet indicates that we have almost 8,810 new incident HCV cases across the country. Among them, 78.2% of these patients visited for HCV disease code at least 2 times in a year, visit the hospital. And among these patients, only 74% are treated with the DAA. This refers of the almost 9,000 new infection patients, only 58% were treated, which is a little bit lower than our target. This is my personal opinion. I think that we may need different strategy and approaches according to the different levels. I'd like to summarize 3 levels. It could be national level and population level or hospital level, because I think these levels may have a different targets and different strategy. The first one I'd like to introduce is the national level. For national level, the target would be, of course, the government, and then strategy should be in Korea. We are trying to adopt HCV antibody testing into the mass health screening examinations. So thanks to our national health insurance system, we have very good national general health screening program in Korea, which is fully funded by our government. For adults, every other years, they have lots of tests free, including some blood work and anthropometric measurements, some questionnaire, and chest X-ray and bone BMD. Our goal is we'd like to put anti-HCV testing into this mass general health screening program as one of the blood tests, because we believe this would be very effective, because the participation rate of this mass health screening program is about almost 80%. So actually, we've done already pilot program for this mass screening. 3 years ago, almost 4 years ago, the eligible patients for this pilot program was those who were born in 1964. At that time, patients were 55 years old. Of the eligible patients, 133,000 Korean people, almost 80% participated in this pilot program. They got blood draw and they were tested to the anti-HCV. 0.75% were positive for the anti-HCV, and among them, 70% were treated with the DAA. An interesting thing was that of the participants, only 6% of Korean people got HCV testing before. That means the rest of the 95%, they never get the HCV testing in their lifetime. So based on these pilot programs, we've done the cost-effective analysis, which shows if the anti-HCV positivity prevalence is more than 0.2%, mass general screening for the general population could be cost-effective. And then, as I mentioned earlier, in Korea, we are estimating anti-HCV positivity prevalence would be almost 0.8%. In terms of the cost effectiveness for the HCV universal screening, we've already published it many times. HCV testing would be cost effective and the ICER is quite affordable, but always the key is in the government. We tried to launch this HCV screening program, but we are still waiting for the call from the government. I don't like this icon, but so for next level, I'd like to introduce the population level. It could be targeting for the Korean general people, and the effective strategy, I think we have to increase the awareness of the HCV infection. So for this, our CASL made many efforts. First one is we provide many broadcasting into the general media using the campaigns, almost 53 times. And then he is the former president of the CASL. So for about 30 seconds, he explained why the HCV is so important. And also HCV is curable these days. The other action we are doing right now is we try to collaborate with other healthcare workers. For example, with dentists, with a physician who are working in the private hospital. Our CASL provides flyers, pamphlets, and posters that can be hanged or they can be attached on the wall in their clinic, and to let the patients who visit their hospital to know more about the HCV infection. The last one is hospital level. Probably the target would be hospital administrative, and the strategy would be increasing the diagnosis and the treatment rate. And we published almost 3 years ago about what happened in the HCV care cascade in a tertiary hospital where I'm working at right now for the past 20 years. And unfortunately, for the past 20 years, there's no big advancement in every step. In our report, HCV RNA testing rate was almost 70%, and unfortunately, the treatment rate was very disappointing, which is about just 35% on average. So I'd like to briefly introduce about the real-C model, which is just started two years ago in our hospital. This is the scheme of the real-C model. If a patient had anti-HCV positivity blood work, and then they do not need additional blood work. So our laboratory department members, they order the HCV RNA testing, and then it will just directly report it without additional blood work, which is the reflex testing. And then if the HCV RNA test comes back positive, and then this news will be automatically notified to the physician who ordered the test. And also it will be automatically registered in critical value reporting system, CVR, in our hospital. And if we got the CVR, and then we have to respond within 2 weeks about what I have done for this. So we compared before a period before the real C model, and then we started from the real C model in patients only, and then it was quite successful. Then we expanded our real C model into our patients. So basically, all patients who visit our hospital, they are eligible for this real C model. So this is the result. The pre-real C model, the HCV RNA testing rate was 51%, and it increased to 66%, and finally it goes up to the 95% of the HCV RNA testing. And more encouraging thing is this one, I think. When we finished the complete real C model, every department has at least more than 90% of the HCV RNA testing. The remarkable stuff is before the model, the surgery part and some non-liver surgery and internal medicine, non-gastroenterology, their rate was quite low. And also after adoption of the real C model, GI referral rate increased and the treatment rate was achieved around 90%. And in terms of the key metrics from the anti-HCV positivity to HCV RNA testing, it was previously 45 days and it goes down to 2 days, which because of the reflex testing. Thank you.
Thank you very much, Professor Joy. Please have a rest. So let's move to the last talk of this session. We are honored to invite Professor Masao Omada. He's the current president of Yamanashi Central and Kita Hospital and also Professor Emeritus at the University of Tokyo. He's going to share the DA-induced paradigm shift in HCV high endemic area of Japan. So, ladies and gentlemen, let's welcome Professor Omada.
Thank you very much. I will touch upon a little on HCV in our hospitals. There is no disclosures. Well, I was in the University of Tokyo for 17 years. The governor asked me to move to the Yamanashi, which is surrounded by the mountains, especially by the Mount Fuji. And then it's west of Tokyo. And then I graduated medical school, Chiba University. Therefore, for the last 53 years as a physician, I'm going back and forth in east and west. And then after moving to the Yamanashi Central Hospital, what's happening in there? I moved 14 years ago. Then if you take a look at the incidence of hepatocarcinoma in Japan, there is some deviations. Western part of Japan, you have a very high incidence of the hepatocarcinoma, maybe due to both B and C. But if you go to the eastern part, including Chiba and Tokyo, there is some area which has a high endemic area. That's Yamanashi. The reason is rather simple, because we had the Mount Fuji, but also we have Mount Fuji now. Sorry, but we had Schistosomiasis japonica there, just like in the Kyushu Islands. Then that's the reason why it's endemic. It's not because Schistosomiasis japonica, but the treatment by intravenous Stivna is used after the World War II. So I moved there 14 years ago. And how we tackle before we go to the discovery of the virus? When I was in Chiba University, I started collecting all the blood samples for the transfused one, and then watch the transaminases. And this is the cases of 14 cases. 80% are showing the continuous fluctuation. We started maybe around 1980. Then interferon was started for HB 1978. So we
we gave this interferon. In fact, J. Hofnanger gave the interferons for the non-A and non-B chronic hepatitis and showing the transaminase normalizations. So I gave this to the post-transfusion acute hepatitis to prevent the future fluctuation of the transaminases. But during the meantime, Michael Houghton found the cDNA. Therefore, we set up a cDNA PCR assays, and then we are collecting the prospective data. And it turned out it coincides with the abnormal normal transaminases, disappearance or persistence of the virus. So this is the very beginning. Then if you go to Japan, and we have 120 million population, Yamanashi is a small county or province, only 0.8 million, 800K. And our hospital established 150 years ago, oldest in Japan. And we have the 0.589 million or 589K medical records in the last 50 years. So population there is only a matter of the 80 million or 0.8 million or 800K. But in 50 years, every year maybe people are dying 7,000 or to 9,000. So altogether, maybe denominator can be 800K plus 500K. Then we have 589K medical records, which is covering almost 45% of the area. In other words, the patient who come to us is from the local area, 97.3%. So among this cohort, what we have done? Well, we are aiming at total elimination near zero programs in Yamanashi. In fact, this is just started. In other words, people came and then give that presentation. So I just collected the data, in fact, in reality. And then, but there is a barriers. Not everybody tested. And even though HCV positive, not everybody tested the HCV RNA. So I explore that. I'm in a position to make things in the hospital. So I asked the people that questions, erase the questions. And then during those days, all registered, the one who has a medical records is 588,000 cases. Then this is the tested cases of HCV antibodies from 2001 to 2002. In fact, 2001 is a data collection of previous 30 years. But as you see, it's obvious. Used to be like 20% testing for all the patients who is coming to the hospital. But nowadays, maybe 40%. But it seems like a little bit down nowadays. So this is a record in 50 years. Then if it's positive, how many are tested? Among those 119K, AB positive rate was 3.5% in average, from 4.8 to 1.6%. Then RNA testing rate was among those AB positive from 46.4 to 20.6%. So it's a matter of 32.9%. So these are the two barrier figures. And in fact, among those AB positive cases, how much newcomers are positive RNA? It's very high still. Average is 64.9%. So if we go all the way to the testing, then you may find that 2/3 are positive for RNA. So among these barriers, we tested, AB tested repeat 20.3%. RNA positive tested 32.9%. Therefore, naturally, we only find 896 patients. But if you do 100% testing, and it might be possible, then they may be just on calculations, 13,379, 14.9 times. But this is including 50 years records. So how about going back to the recent years? 109K came to ICH, AB tested 36.2%, RNA tested 28%, 5%. So it turned out among those 9 years since DAA started, 149 new cases discovered. But if you do that, and maybe pharmaceutical industry is interested in this particular figures. 9.7%, times 9.7. So in all time, more than 10%. But even the last 9 years, it will be 9 times we could have found. So naturally, what department is doing these kind of things? So therefore, I checked who tested or not tested among the department. And it's obvious. Well, gastroenterology is okay so far. But if you go to the emergencies, the majority are not tested for RNA. I think it's quite reasonable because they have to save their life. So by this data, how do you go? I mean, we got to think about the cost effectiveness and everything. But anyhow, since I got this data, so maybe from April 1st, I may do something on my hospital. But anyhow, summarize by calculating the evidence of the infection by RNA levels from 2001 to 2007, 30 years time, 2.91%, and then 2.52%, 7 years, and then for the recent 9 years, 1.3%. So whether do you call this accomplishment or not, I'm not really sure about, but if we are aiming zero strategies, maybe this is on the halfway. But anyhow, I repeat, our area is a very much surrounded mountains, beautiful Mount Fuji, but also people communicate not much from outside. So it's very nice to conduct and continue epidemiological studies. And then as I said, 40% of the residents have our IDs because we are the general center hospitals and all the choppers and all the emergency ambulance came to our hospital. So this is what I saw in the last 14 hours. I left the University of Tokyo. So I acknowledge all those things. This is the Chiba era about Dr. Okuda, and then Kato sensei is not here, but it's also Kato sensei is not here either. This is a 17 years Tokyo University. And then now these are my younger colleagues. Thank you very much. Sure.
Thank you very much, Professor Omada, for the comprehensive sharing. So let's move to the panel discussion. May I invite all of the 4 speakers on the stage? And also, may I invite Dr. Jung Ho, Dr. Jung Wo? Maybe you can join me. Okay. Okay, any comment or question from the audience? Okay, please.
Thank you very much to all the speakers. If I may just begin with a historical question and to Dr. Amata. And I was very interested in one of your slides, your first slides, talking about schistosomiasis, I guess in the late 40s, early 50s in that particular region of Japan, and that the treatment, I assume with praziquantel, or maybe it was something different that contributed to the spread. And I've been very involved with the Hep C response in Egypt. And of course, that was very much pinpointed to the schistosomiasis elimination campaign during the sort of the 50s and 60s. So my question was, what are there other examples of schistosomiasis? Because this is the first time I'd heard that Japan, that was probably one of the earliest contributors. And then it was the lack of the diagnostic test for screen blood. But could you just elaborate a little bit more? Because it is an interesting historical observation.
Yes, that's a pretty good question because majority are transfusions, obviously, and not many drug users. But then about psoriasis, it's because of Stivnal. That's the name of drugs. You got to shoot into the veins. That's why it's spread it. But the majority are transfusion in the hospitals. That's number one. Japanese would do some drug use to activate you, but not many. So that I would say 90% due to the medical practice, and then drug shooting maybe 5%. So Mansoni maybe the rest, in particular that area. That's my comment.
And when was schistosomiasis eliminated?
Small, but significant in those days.
In those
But
days,
after that, majority, well, because otherwise you can explain the things in the western part of Japan.
Thank you.
Okay, please.
Yeah, Dr. Choi, I'm intrigued by the data where you're able to line up all of these 55-year-olds and test everyone. I mean, that's a heroic and very important effort. Now, were you able to ascertain when these people might have potentially been infected, those that were positive, and any that might have had ongoing risk behaviors for HCV acquisition or transmission?
You know, I said 50 years back, and you may ask how come you can do that before the discovery of the HCV, because the big discovery was 1989. So, but fortunately enough, they come to our hospitals, repeaters. So they come, even the first visit is 50 years ago. If they are the age 20, they might age 70 when they came today. So we test it. And the majority, as I said, is a transfusion. Because in Chiba area days, I did so many blood sampling tips of the blood. And then I would say, normal baseline transaminase, if you got a transfusion, 10% show the fluctuations. That's why motivated me to study by interference to stop fluctuation. Because you remember that J. Hoffner is the one who put a paper in New England Journal about normalization of ALT by interference in cases only 17 or 18 cases. But I thought fluctuation prevented, that may indicate the virus disappearance. But those days, there is no way. But Michael Houghton show us DNA fragments, cDNA fragments. So we set up, we have a laboratory. So we are able to make our own. And then because follow-up length is 5 years, so during the time we had the blood sampled. So we tested. And then that's concordant with the disappearance of virus. That's the very, very beginning. I'm not that young anymore, you know that.
Any question or comment from the audience? Okay, maybe I have a question for the professor from the 3 countries. I think the national health insurance system is quite similar among the 3 countries. We also have the nationwide insurance system covered by the governments, and I think the coverage rate is maybe 98% or more in all of the 3 countries. So currently, it maybe have no barrier in the treatment rates and also referral treatment. So how about the strategy to increase the screening? I mean, does the national health insurance allow the universal screening, at least for the hospital-based population? May I have the opinion from the 3 speakers for Taiwan, Japan, and Korea?
Yeah, since the reimbursement and diagnosis is universal, so there will be someone that undiagnosed or treated. And in our model in Changhua County, the most available is the public authority, as well as the basic local health center in community. So that's where help to find out the patients who was diagnosed or was not treated. And we have to find someone maybe who have been previous antibody positive, but not into care of RNA testing. And we rely on the basic community, local health center, and public health bureau very much. I think it is the most helpful in our model. Thank you.
Okay, in Japan, in terms of public testing, the whole money was covered by the government. Well, as a copay things is also included, but so mainly the financial support was provided from the government. And well, the problem is I mentioned in my presentation the workplace examination, because due to some private information matter, it is very difficult to grasp the whole situation, what happened in the workplace in Japan. So younger people tend to go to occupational examination, but it is not including hepatitis virus test. So probably, so we have to track on that. But otherwise, well, Japanese surveillance system is well covered by governmental support.
I think even though we tried many times to persuade our government to put HCV testing into the mass general screening program in Korea, I think the government position is that the HCV prevalence in Korea is quite low. And even though we keep saying if we just remove the HCV infection at earlier stages, it can save more money. If the patients are left untreated, government will spend more money to treat the HCC patients and liver cirrhosis patients. But usually the government try to save more money. They do not want to get more taxes from the general people. And then they want to see more, they want to some achievement in an earlier period. They usually do not think about what will happen in the long run. And also the other issue, this is my personal opinion, is the other issue is the regime and the government after the election. Usually they rapidly change the healthcare policies, and also it also affects the issues, because I think we've almost reaches to put the HCV antibody test into the mass general program, but anyhow it will be delayed and keep delayed. So I think that this issue, even though our hepatologists think that this is very important issue for the society health problem, but the magnitude of the importance the government has is we have very discrepancy between the government and the hepatologist, I think. And also the other issue we may have is, even though most of the costs are supported by National Health Insurance for the DAA, but still the co-payment is quite expensive. And then it costs almost $3,000 even after the copay, even after the insurance. So some people still are not affordable for these expensive TAAs.
Please.
I think if it depend on the policymakers, maybe you cannot decide yourself because the government decides that you cannot do anything. So in my case, I try to do the best and then try to test every single person who come to my hospital, because we have about 1,000 to sometimes 1,700 outpatient clinics, and the surgeon does the testing, every single ones. But as I showed, only 40% in total. So we can make it 100% and then show the models to the other people to convince. And by doing that, you are not relying on, I mean, you don't need to be dependent upon the policymakers. That's my ideas, and so the way to go.
Thank you.
Dr. Ahmad, since you have the microphone, your remarks make me recall when we were having our conversation about this forum. You were saying, I'm in a position to do pretty much anything I want at the moment. And I was curious with
sorry about can you give me 1 minute? Yeah. Sorry about the government, sometimes very enthusiastic about one things, but then fever's out. Yeah, so you got to do yourself.
Yeah. But I was going to follow up to ask you, based on your data, and the large number of clinics that you just mentioned, are there any kind of new directives you can give to the clinicians in those settings regarding the priorities for testing for
You know,
hepatitis
the
C?
key is not telling the RNA positive, but by elastography or other methods like a platelet counting, Apley score, FIB4, I tell this may be having a stage of F2, F3. So not just telling the like a GI, OBGI people or pediatrician by this patient, 10 year, not a 10 year, like 72 years gentleman F3, so the maybe occurrence rate of cancer a year could be a 1 to 2%, or maybe at most 3%. So I will add the comment, not just positive RNA. That's what I do.
Thank you. And a question for Dr. Choi, and maybe this turn it over to Kerry James here. I was, Dr. Choi, governments make decisions for multiple reasons. One of them is financial. The other is political and influence by members of the public. And I wanted to get your view on what could get this decision over the goal line. Is it just more cost effectiveness modeling, or do you think it's more a role of community advocacy to send the message that this is what patients are seeking from the health system?
Yeah, I think even though we provided many times it could be cost effective, but government usually doesn't want to hear about cost effectiveness.
Okay.
And I think like Dr. versus some influencers, for example, some idol members or some famous teenager talents, if they got the HCV infection from the tattoo, if they were successfully treated the DAA, and they can be, I think, more impact than that we can, even though we keep saying, hepatology keeps saying HCV infection is very important into the audience, into the population, but I think there's some influencer or some famous YouTubers, they have a more impact than us. Then I think collaborating with them also can be an option. But for the government, I think always the working with the government is all very, very hard. Yeah, and also still, again, the HCV prevalence in Korea is quite low compared to the other country. So mostly our government is more focusing on hepatitis B rather than the Hep C. That is another barrier. Then we cannot persuade the government.
Yeah.
Please.
Kerry?
Thank you so much. Hi, I'm Kerry James from the World Hepatitis Alliance. Thank you all for your presentations and the amazing work that you're doing. Just wanted to ask you a question about a pilot that's been happening in London, where they've been doing in emergency departments in all the London hospitals, they've been doing opt-out BBV testing for HIV, hepatitis B, and hepatitis C for all blood drawn in emergency departments. And they've been very successful in identifying all three. Actually, they're finding 3 times as much hepatitis B than anything else, which was a big surprise to everyone. But obviously, this can be a slightly controversial topic because it's opt-out and everything. So I just wanted your opinion on whether you think a program like that could be implemented in your country, or how do you think acceptable that would be in the APAC region in general? Thank you.
I've been working for the 3,000 HCV positive patient for 17 years. So I have a basic data in the areas, and I tell the risks of the developing cancer because they are the local people. So even though the emergency brought in the traffic accident, but they recover. So at the end, maybe if the patient's traffic accident, young drivers or 30s, I may say, well, in lifetime, you may have expectation of the occurrence of cancer 15%. Then I may ask the doctors to decide.
Question for Dr. Hu from Taiwan. That was an excellent presentation and really a great example of integration of hepatitis into the diabetes care system. It was quite remarkable, the high prevalence of hepatitis C among persons with diabetes in that part of the community. It brings to mind the relationship between hepatitis C and diabetes, of course, that hepatitis C can increase the risk of diabetes. And so that may be one of the reasons for the increased prevalence. But then it also brings to mind the multiple hepatitis B outbreaks we would get in the United States because of unsafe injection practices, as from glucose monitoring examples, such as in residential care facilities for the elderly, et cetera. So just wanted to get your thoughts about what were the reasons for that high prevalence in these areas.
Yeah, the high prevalence of Hep C in diabetes might be resulted from the extrahepatic manifestation, but it is not limited to diabetes. In our data, you can see that more association to chronic kidney disease or cardiovascular disease. However, the close association is not seen in our data for hepatitis B. So I think for CKD and diabetes, they belong to extrahepatic manifestation. If we treat all the comorbidity, we can stop the progression of chronic kidney disease or diabetes control. That would be cost-effective, universal when compared with universal screening. Especially the diabetes or CKD patient are maybe older than general population in general. So in our experience, maybe for cost-effective, we only have to surveillance for a patient older than 40 years or 50 years. It is enough to achieve the elimination of HCV. And yeah, so the comorbidity is very important for elimination, is our experience. It is very cost-effective when compared with universal screening.
Since Egypt was brought up earlier, as you probably know, Egypt integrated their hepatitis C screening with diabetes screening and obesity screening. So there was a relationship there, but not to this level of actually integrating diabetes care with hepatitis C care. So it's really an excellent, again, example of integration.
The other reason for diabetes and CKD patient, since in Taiwan, we have co-care system for the CKD and diabetes populations. So the co-care system has already been there. So there are complete list for those patients with regular visit. So the thing we only can do is just plus HCV testing in their regular visit. It is very simple, no duplicate of paperwork, and there's no extra patient visit.
There used to be the studies by saying HCV induced diabetes. There is a molecular biological studies, but then we eradicate the virus. But I don't see the tendency that improves. So, a theological basis, it's very hard to believe now clinically the HCV induced diabetes. So maybe there is some other reason why you have very high incidence on that you are diabetic.
Maybe, however, in our data, we always show the prevalence of HCV infection in diabetes is 2 to 3 times of general population. In any other surveillance, either in geographic or
Sorry, how much I missed? Two times, 3 times? How much percent in the absolute?
6 to 7%.
Oh.
So I have a question for Professor Ikegami. In your presentation, I saw that the anti-HCV prevalence rate increased from 2015 to 2020 in the Department of Orthopedic, almost stomach. So it's quite interesting why this patient, the outpatients outside the specialist have an increase in the anti-HCV prevalence.
Thank you very much for your question. Actually, the number was just on HCV antibody positive persons. Actually, we screened that persons after getting the test result with the PCR. So around 10% or something of all HCV positive persons are they are active they have active infection. So I'm not sure why the end of the series the number of the HCV positive patients are increasing, but probably just after the pandemic, maybe the many elderly person that visit the hospital, probably. I'm not sure about that. The reason why the prevalence of HCV positive, antibody positive persons that increase at age, but the actual number of active infectants are pretty low, even in that, the pre-operative tests are positive persons.
Okay, thank you very much.
Same question. Thank you.
Anything
else?
Anything else? I think we almost are run out of time. I would like to thank all the speakers and also the audience. And thank you very much. And and finally, I would like to invite Dr. John Wall for the final session call to action and give us a closing remark.
Thank you. Thank you again for excellent presentations and excellent discussion. As I mentioned at the start of the forum, we really wanted to recognize how the importance of keeping hepatitis elimination as a top of mind goal around the world. And we've heard multiple reasons for why that has to be the case, so that we can sustain good programs that you've heard about from Taiwan and from Japan and from Singapore, while we need to help other countries that I touched on, such as Vietnam or Myanmar or Bangladesh, Pakistan, get going through sharing lessons learned and validating their direction. And then recognizing the importance of working together, such as the partnerships that are represented in this room, actually, academicians, clinicians, public health officials, industry, community leaders, all play a role. So we thought it would be fitting to end our forum, with a call to action to exemplify our shared commitment toward hepatitis elimination. And then we could then use that call to action to send to ministries of health or to other key stakeholders to show, like, this is a really important issue. You have an important, influential constituency that's committed to it. And then people will take note more so than they are currently. So we put this together, and I'm going to ask all of you, if you agree with it, to come forward, as sign a version, and we have a pin for you while supplies last. But basically, the call to action is that, as a group, we're concerned about hepatitis elimination in Asia, that we're calling, as we've heard, about the WHO global strategy with goals for hepatitis elimination that have been endorsed by all member states in the World Health Assembly, recognizing that we have achievements to build on that we've heard about today, in part recognizing government's commitment to hepatitis B and hepatitis C elimination, demonstrating the feasibility of putting together effective programs with that commitment. Also recognizing other achievements, such as Asian countries reducing to less than 1% the prevalence of hepatitis B surface antigen through high hepatitis B vaccination coverage. The only UN Sustainable Development Goal achieved in 2020 was this goal, in large part because of the work of Asian countries. The robust toolkit that we've heard about today of strategies and technologies that simplify hepatitis C testing and linkage to care in particular. And the prospects for functional cures, which we're hearing about at APOSL, and the lessons learned from research and new policies that we'll be hearing about on Saturday that hold promise for expanding access to hepatitis B testing and treatment. However, we note with concern, as I touched on, that over half of the 350 million people with hepatitis B are living in Asia, that only 1 in 8 persons with hepatitis B are diagnosed, only 1 in 30 are receiving treatment, only 1 in 5 persons with hepatitis C are diagnosed, only 1 in 10 are receiving treatment, and the loss in productivity as a consequence of that premature mortality and disability is harming economies in Asia. So we'd like to raise awareness that hepatitis elimination can be contributors to national productivity, which will be of interest to national governments. That hepatitis C elimination can have profound health impact and improved health through reducing disabilities. And so the call to action calls on governments to have good data to assess their burden of hepatitis B and hepatitis C, including access to testing and treatment. Use those data to develop effective action plans with financial strategies to put those plans into place. Sustain coverage of what's working already, such as hepatitis B birth dose vaccination to prevent mother-to-child transmission. To update and implement policies based on new data and revelations of what can work more effectively in their countries, engaging all stakeholders, including the importance of engaging civil society, who have the most to benefit from those policies and are at greatest risk of harm when those policies are not put in place. To meet targets for high-risk populations, such as persons who inject drugs, and always look for ways of building partnerships to engage public and private partners to provide resources and expertise. And encourage legislation to end discrimination such as stigma, job restrictions, etc., that harm people and make people feel like the risk of knowing one's status exceeds the benefits. Then we call on clinician organizations, including APOSL, to recognize the need to strengthen specialist and non-specialist provider skills so you can decentralize hepatitis care into health systems, expand guidelines so that you can expand access to hepatitis B and hepatitis C treatment, recognizing that the expertise such as in APOSL has critical roles to play in developing that national policy. And we heard examples of that here in the forum today. Promote integration with other clinical services. Again, we just heard an excellent example for the diabetes and HCV treatment services, and then have those networks set up so when those more complicated patients can be referred to specialists such as hepatologists. And then recognizing that operational research is needed throughout the journey toward hepatitis elimination. It's important for all of us to participate in that, to see what's working and what's not and how it can be improved, and to have communities of practice such as what's represented in the room today to share lessons learned. And then for communities, convene local coalitions to launch programs and sustain political will for hepatitis elimination. And those coalitions need to include all stakeholders, such as all of us in our room today. Raise awareness of the threat of viral hepatitis and the benefits of hepatitis elimination. Government officials, and including the transition from one government to the next, you have to be in a continued education mode to raise awareness of why this is important and look for those opportunities to have an impact in policy development. And then again, seek ways to reduce stigma at the community level, providing other assistance for persons with hepatitis, in their families. And then through all of that, recognize all of our roles that we are seeking to play and have respect for those roles, whether it be clinicians, health officials, community leaders, industry, and political leaders. And that really are seeking to have a sense of unity of purpose, and that we share a commitment of working together till goals for hepatitis B and hepatitis C elimination achieved. You have to go. Will you sign it, please, before you?
For what?
This is the call to action that I just read.
Yeah, but I have not read that. So
Okay.
later,
Wait,
yeah,
you take
yeah,
it.
okay, thank you.
Yeah, thank you. Okay. So this is it. So you can, the QR code is to join the call to action to eliminate hepatitis in Asia. You can read it here electronically. We have versions of it here. And so I would appreciate if you, for those that agree with it and have time, please come forward and sign it. Thank you very much. Come forward and show that you're part of the global coalition to eliminate hepatitis by citing this call to action. I think that would be a great show of support and a fitting way to end this forum and to be a product of this meeting of APOSL. Thank you.
Yeah.
You too. I'm excited. Nice to meet you. You were very dedicated sitting at the front. Yes. So.
Yeah, he did.
Thank you.
Thank you.
Thank you. Yeah, good to see you in person.
Yeah, yeah, yeah.
Thank you. Yeah. Yeah, we will tomorrow. Enjoy the rest of the day.
You got anywhere, just on the margin. We're gonna put it all around. We'll try to, yeah, we are. Okay, if you will hang, yeah.
That's too high.
You can also get a. You can also have a fresh one.
Okay, I'll start the first one. I'll start the first one. Very small. Just as much as putting it online. Is that right?
Thank you. Yeah, okay, thank you, thank you.
So you don't need this online also? No, all these people, you don't need it, but is this just as efficient as online? Okay, that's why, so I'm not, I thought that here you just have, this is more like a ceremonial. We're all here.
夜はなんかユニバイテッドディナーどうするんですか？今からポスターが
But it'd be better if you have Pepsi stream on and then Pepsi stream and then Apple stream and then spread it It's all Hep C today, and there's no more Hep C after today. Like pure Hep C. But anyway, I thought most of it. Yeah, Dr. Choi, I heard that. Anyway, keep getting, but we'll do it online. Slides. Hey, John, who's controlling the slides? If they put the QR code up again, we'll kill two birds with one stone. Yeah.
Yeah. Again, please go to the QR code to sign your name electronically if you would like. Thank you very much.
All right, great.
Yes, we would buy.